Hi, this is a video on how to identify and classify uterine malformations and adenomyosis and endometriosis using 2D and 3D ultrasound. My name is Suzanne Johnson and I'm a gynecologist from Southampton. 3D ultrasound has a lot of uses, but in this talk I'm going to limit the discussion to congenital uterine anomaly, adenomyosis and endometriosis. Congenital uterine anomalies. You can diagnose the shape of the uterus on MRI, a combination of laparoscopy and hysteroscopy, or on 3D transvaginal ultrasound. The standard uterine views in the longitudinal plane and the transverse plane are all very well, but if you suddenly get a transverse view that looks like this, where you've got a bit of cavity here and a bit of cavity there, you don't know what this kind of abnormality is, and that's why you need 3D. In 3D you can get the coronal view, and this distinguishes between various of the abnormalities. The coronal view is the view in purple here, which divides you into a front half and a back half, and that will allow us to categorize the uterine abnormalities. So how to get a good coronal view? The best scans are done in the luteal phase because you get really nice contrast between the endometrium and the myometrium. Do the scan transvaginally or transrectally. Optimize your 2D view because your 3D is only ever going to be as good as your 2D. Select a region of interest, in this case the uterus, take the 3D volume and then look at the coronal view in sectional planes, or you can render the volume looking at the coronal view that way. So as I said, you optimize your 2D image. You then select your region of interest, take a volume. That's then going to display in sectional planes, longitudinal, transverse and coronal, and you can also render that and give you better views that you can play around with more in the rendered coronal view. There's another way of doing it, is that on some of the machines from GE there's a touch screen and you can draw a line on that, and then hey presto, you get the coronal view. The first time I saw this I was completely blown away. This makes life so much easier. The other way of rendering the image is sometimes better, but this is a really quick way to look at uterine shape. So how does the uterus become an abnormal shape? How does the uterus form at all? This is a very good review telling you in detail how it works, but let's just say you've got Müllerian duct on each side, you've got the Wolffian duct on each side, and these things are formed, then they fuse, and then you get absorption of this central septum. And if the process goes wrong at one of these stages, that's when you get an abnormal shape uterus. The American Fertility Society published their classification system, and this is a very old system and it's been much superseded, but people still refer to it sometimes. This is my favorite classification system. It was published in 2003 and we'll talk about it in more detail in a minute. The way that it discusses uterine shape is that you've got a normal shape, or arcuate, subseptate, septate, bicornuate, didelphous and unicornuate. But we'll talk about that more in a minute, because in 2013 Eschre and Esge published this guideline. I found it quite difficult to use, but more recently in 2021 the ASRM published this classification system. It is fantastic. It's incredibly similar to the Jurkovic one, but if you take a picture of that QR code you can go to that paper, and what it does particularly nicely is per variant give you the classification, treatment, presentation, what it looks similar to, and suggestions for imaging. So this is, and you can have this as an app on your phone. It's very good. But I've stuck with this one. It's very, very similar to the other one. I just want to show you some pictures. So this is a coronal view of a normal uterus on 3D ultrasound. So this triangular shape here is the endometrial cavity. This here is the uterine fundus. This is the right side, this is the left side, and this is the cavity going down toward the cervix. So in a normal shaped uterus, you've got a flattish endometrial fundus here. In the cartoon it looks like that. Now this is an arcuate uterus where you've got a dip here, a fundal dip into the myometrial cavity, and if this is less than 10 millimeters and if this angle is more than 90 degrees, then that's an arcuate uterus. This is extremely common, of course. A subseptate uterus, you've still got a nice convex myometrial contour here, but the dip in the in the endometrial contour is more than 10 millimeters, and this angle is less than 10 degrees. So this is a subseptate, so there's a septum, but it doesn't go all the way down to the cervix. In a septate uterus, again, you've got that normal fundal contour, but this dip now goes all the way through to the cervix. It's more than 10 millimeters in length. This is less than 90 degrees, but you can follow the septum all the way through. So this is a septate uterus. When you have a septate uterus, you can see I've taken a volume here just off the cervix, and you can see that that septum goes all the way down. So there are two cervical canals here, endocervical canals, and sometimes you have one cervical body, sometimes two, it varies. In a bicornuate uterus, you can see here in the image, you've got a fundal dip in the myometrial contour. So that's what gives you these two separate horns, a bicornuate uterus. So here I've got one cavity going down and another cavity going down, but the difference here is this dip is more than 10 millimeters. Less than 10 millimeters is quite common in a normal uterus, but once this dip here in the outside of the myometrium is more than 10 millimeters, it's bicornuate. A didelphous uterus is where you've got two separate uterine bodies completely going into one cervix or two cervix, and this is almost impossible to capture on transvaginal ultrasound because these horns act a bit like bunny ears, so you'll get one flopping forward and one sideways, and you just can't capture it on TV. This is a transabdominal image of these two separate uterine bodies. Quite unusual. And in this didelphous uterus, you can't capture the whole thing in one screen, but you can take one uterus at a time. This is one horn, that was the other horn. And then going to the cervix, I could follow the endometrial and endocervical canals, showing that there was one cervix but with two canals. So this is a didelphic uterus with one cervix. Now this is a very common abnormality, the unicornuate uterus, and on 2D ultrasound you can see it looks completely normal. We've got the anterior aspect of the uterus, the fundus, the posterior wall, and the cervix here, cervical canal going into the endometrial cavity, nice thick luteal face endometrium. Looks normal in the longitudinal view, and in the transverse view we often rush that a bit, don't we? But you've got to really look carefully, because if you look at the endometrial cavity here, you can see it's circular. No matter if in the transverse plane you go up to the fundus, that stays a circle. That's not normal. If you then apply 3D, you can see it's really not normal. This is what it looks like a banana shape, and that's what we've drawn here, a banana shaped unicornuate uterus, and it may or may not have a communicating horn or a rudimentary horn that may or may not be communicating with the main cavity. So this is very underdiagnosed because people don't stand still long enough in the transverse plane. If you find a unicornuate uterus, you've got to look for the rudimentary horn, and in this is the transverse plane. There's that circular endometrial cavity. This looks a bit like the ligament going toward the ovary, but I found the ovary separately, and it was hard to know exactly what is this until I put 3D on, and then you can see endometrium with a junctional zone. So this was a rudimentary horn that was not communicating. It was attached, but there was no endometrium in between. So very important to diagnose that, because this can cause a lot of pelvic pain. Then there are variations. You can have a combination of abnormalities. You can have one or two cervical canals in one cervix or two cervices. You can also have a vaginal septum, which can be longitudinal or transverse. It can be complete, so no blood gets out, or incomplete, and that can cause a hematocolpos or a hematometra or both. And it's very important to diagnose this because there's an association with endometriosis, especially if the outflow is obstructed. If you get a lot of retrograde menstruation, it seems to be potentially causal of endometriosis. And also look at the kidneys. There are associated renal abnormalities, particularly with this one particular abnormality called overa. And I just want to tell you a little bit more about that because it's more common than you would think. What this means is you have a double uterus, you have a hemivagina here which is obstructed, you've got a complete septum walling off that whole side, and also you're missing a kidney on that side. So although somebody will be menstruating through this half of their uterus, this other uterus, the blood can't get out, so you get retrograde menstruation, you get can get tremendous pain and endometriosis, and this can all be very painful. Very important to diagnose. You can diagnose this on ultrasound. And then there's one thing that is not in the ASRM guidelines or in Yurkovic's paper from 2003, and that's the T-shaped uterus. And people finding it difficult to get a consensus if it's a thing or how you diagnose it, what the measurements should be. And so I'm just telling you that that's something that's not covered, and we don't describe that at the moment. So on the topic of abnormal uteruses, some unusual pregnancies. This is a very early pregnancy scan, and you can see that there is some endometrium here, and you can see a pregnancy here. So what exactly is this? You take a 3D, and you can see this is a septate uterus. The septum goes all the way down. You've got one horn, and you've got another horn. There's a pregnancy in this horn on the right side. So there's a little bit of a fundal dip. That's fine. This is a septate uterus with an early pregnancy. Nothing to worry about. You need to report it, obviously. This, on the other hand, looks really quite similar. You've got some endometrium here. You've got a pregnancy there. But when you do this on 3D, look what's happened. This here is a unicornuate uterus. You can see that's that banana shape, and this is a pregnancy in the rudimentary horn. Very important to diagnose, because this will rupture sooner or later and be potentially catastrophic. One other thing I couldn't help myself from showing you, you see this in a normal uterus, but in the transverse view, you've got the cavity there, you've got some kind of pregnancy here, you've got the ovary here. Very difficult to know what is this exactly. Put your 3D on, look, it's an interstitial pregnancy. This is the transverse plane, and this is the edge of the endometrial cavity. This is the first portion of the interstitial tube, the fallopian tube, and then this is the pregnancy sitting in that interstitial portion. Important to diagnose. 3D really helps you with that. So adenomyosis is another thing that we wanted to talk about. What is it? This is a condition that's usually diagnosed in women between the ages of 40 and 60, but you can be younger, and you can in fact see it in teenagers. And it's caused by the growth of ectopic endometrial glands and stroma into the myometrium. You can get it from the outside in, where the endometriosis on the outside of the uterus grows into the external myometrium. I'll show you lots of examples. So how common is endometriosis and adenomyosis? Well, this group showed that people coming to a general gynae clinic, 1 in 5 of them had endometriosis, and 1 in 3 of their patients had both endometriosis and adenomyosis. So it's much more common than we think. What symptoms does adenomyosis cause? Well, it can cause menorrhagia, very heavy periods, so heavy that people get iron deficiency anemia, painful periods, painful sex, menstrual bladder symptoms, pressure, back pain, bloating, and subfertility. This is a lovely paper describing how endometriosis and adenomyosis can cause subfertility and reduced pregnancy rates, reduced live birth rates, because they can cause an increase in miscarriage and an increase in various adverse obstetric outcomes. So very important diagnosis to make. How can we image adenomyosis? Well, MRI and ultrasound are equally good. So that's very lucky, because ultrasound is what we do. The MUSA group in 2015 gave us a system, language, and technique for describing adenomyosis. So they've written several papers since then, and what they've settled on is this definition. There are direct features which define adenomyosis, and also some indirect features. Let's start with the direct features. If you get myometrial cysts from the endometrium growing into the myometrium, or you get these hyperechogenic islands of endometrium in the myometrium, or this is the very beginning of it, these very fine lines and buds coming from the endometrium into the myometrium. These 3 are direct features of adenomyosis. So if you see those, you can say this is adenomyosis. There are also indirect features, and the indirect features are asymmetrical thickening, and that's caused by the fibrosis surrounding these things, a globular uterus, an irregular junctional zone, endomyometrial junction, or where it's interrupted. If you see some adenomyosis, the colour runs straight through it, and you get fan-shaped shadowing from all these tiny little cysts that cause this fan-shaped shadowing. So there are direct features and indirect features, and we need to look for them to exclude adenomyosis. So the Musa group describes their technique in 2D, but also in 3D. In 3D, you can look at the uterus again offline. You could get a second opinion from an expert. And in both the multiplanar view and the coronal section, you can look through all the planes and you can look at the endomyometrial junction and its shape. And it's a very, very useful technique. So we talked about it before, that you take a volume, you then get your sectional planes, longitudinal, transverse and coronal, then you render that into a coronal plane that is nicer to work with. But when you look on 3D, you can then really define the endomyometrial junction. So I've just taken this example here. When you've taken your volume in your rendered view, you can then use different colors if you like. And so I've gone for a slight yellow because for my eyes, that helps to define the endomyometrial junction or the junctional zone more clearly. So when you've got this dark line, and sometimes you need to rotate this image a bit to get it nice and clear on both sides, but that's a normal junctional zone. We're not seeing any of this white crossing of the endometrium into the myometrium, so there's no adenomyosis here. So if we take an example now, a patient attends clinic with pelvic pain and with or without menorrhagia, let's say, but there could be other symptoms as well. The IDEA consensus, this was a paper published looking for the definition of endometriosis. In their first of 4 steps, and you can do these in any order, but this is my order, in their systematic routine pelvic ultrasound, they say look for features of endometriosis starting with adenomyosis. So we're going to start with that. Now, the GE machines have got the IDEA Scan Assistant on their systems, and it reminds you of step 1, step 2, 3, and 4, and it will then take you through those steps in a stepwise progression and show you images of what those conditions look like. So here they show an image of adenomyosis, but they also show nodules of deep endometriosis. So it's very useful to use this Scan Assistant. So let's start with our systematic pelvic scan, step 1 of the IDEA protocol, looking for features of endometriosis. And in this case, this is an anteverted uterus, which is retroflexed. Flexion happens at the internal os. So in this anteverted uterus, you expect it to be anteflexed, but it's retroflexed. It's retroflexed because it's being pulled backwards by adhesions, and this is called the question mark sign, as published by Nadine Di Donato. So that makes you think there's probably going to be endometriosis in this pelvis. And then we look for adenomyosis. And in this video clip, what you can see is a bulky globular uterus with small myometrial cysts, stripy shadowing, and a very indistinct endomyometrial junction. You can see the endometrium just about, but you can't clearly see the edges. This is another video clip of adenomyosis. These are islands of endometrium in the myometrium. And when you take a 3D of that, you can see that you've got a very irregular endomyometrial junction. This is absolutely diagnostic of adenomyosis. So this is another example where we've got a very thick anterior wall and a thinner posterior wall. It's usually the other way around, but it can be that way. Other features are this, where you've got the adenomyosis, this translesional vascularity, the opposite to what a fibroid does, where it goes around the edges. The vascularity goes through the lesion. And then the stripy shadowing from all these little cysts that let more sound through, and then next to the cyst you get the shadowing of the myometrium, so you end up with this sort of luxiflex effect. So in this little video clip, what I'm going to show you is an indistinct endomyometrial junction. Again, it's quite difficult to see it clearly. There are these endometrial islands in the myometrium, there are cysts in the myometrium, and there's vascularity throughout this adenomyoma. So you can see that's a severe adenomyosis. On 3D, I just wanted to remind you that's the normal, and we can see the normal junctional zone here. But on 3D, in that last case, you can see that the endometrium has invaded the myometrium, and you can see that there are myometrial cysts in the myometrium as well. And sometimes you see adenomyosis after septal surgery. So this was a congenitally abnormal uterus where the patient had a septum removed and she's ended up with adenomyosis. And in this case, where a person had endometrial ablation, and you can see that this is the original cavity, this is where the ablation has happened. You've got myometrial adhesions, so no endometrium, and the endometrium seems to have grown into the myometrium just there, so the patient will have continued with her symptoms. Again, this is suggestive of retrograde menstruation causing these problems. So how can we classify adenomyosis? Thierry van den Bosch published this paper, and we are not going to do every uterus to this level of detail, but it's useful to have a system to have in your mind that if you've diagnosed adenomyosis, you look to see where in the uterus is it. Is it focal or diffuse? This is the important bit. Then are there cysts or not? Which layer is involved? What's the extent of it? And what's the size of any particular lesion? But we're only going to look at whether it's focal or diffuse. So the direct features of adenomyosis, we said that they were the subendometrial lines, the buds, and the islands. And then we have to look at, if you see those things, whether that's in a large area or a less large area, whether it's focal, whether it's diffuse, or whether it's an adenomyoma. And the definitions they've come up with are very good. If it's focal, is if more than a quarter of the circumference is surrounded by normal myometrium. It's diffuse if less than a quarter of the lesion is surrounded by normal myometrium. And an adenomyoma is where you've got demarcation by hypertrophic myometrium, but not a capsule. You don't get a capsule with adenomyosis, in marked contrast to a fibroid. So a fibroid you can peel out, but an adenomyoma, there's no capsule. You can't peel it out. It just bleeds. But if the myometrium is a bit hypertrophic, and so you get a better clear delineation, that's called an adenomyoma. So adenomyosis can be focal or diffuse. Now, within the focal, and I'm sorry about that, but here we are, in the focal there are 5 types. It can be focal when it's focal on the outside of the uterus. This is what we've been talking about, focal in the myometrium. But if you've got a big cyst in the myometrium, that's called macro, and there's another condition called acum, and we're going to just talk about those in turn. If you've got focal adenomyosis in the outer myometrium, it can be in the anterior compartment near the bladder, or it can be in the posterior compartment by the bowel. And what it is deep endometriosis nodules that invade the uterine serosa from the outside in. So here is a retroverted uterus, and this is growing into the back wall of the uterus, and it's often in combination with a bowel nodule. So I'll show you an example. This patient was 38, had horrendous periods since she was 16. When people pass out and get admitted to hospital, you know this is very abnormal, and there's going to be something to find. Severe pain on opening her bowels during a period, that's called dyschezia. No children, and she'd never had any surgery. So that's a image showing an anteverted but retroflexed uterus. In this image, you can see deep endometriosis at the torus. We'll talk about that in a minute. But you can see that that deep endometriosis here is invading the myometrium, and here is a bowel nodule of endometriosis. So this is endometriosis invading the uterus, and it's then called superficial adenomyosis. So in this image and in this little video clip, you can see the deep endometriosis invading the back wall of the uterus. That's superficial adeno, and there's a stenosing bowel nodule, and that's why she had such pain on opening her bowels during her period, and there's one of those there. But we'll talk about more of that in a minute. So you can also have superficial adenomyosis in the anterior compartment, and this is an anteverted uterus, and you can see I'm pressing very, very gently with my TV probe. There's the bladder, and here is a lump of endometriosis that's gluing the bladder to the uterus. And on 3D, a lovely image, you can see the deep endometriosis nodule, and you can see it's not in the muscularis of the bladder, but it is in continuation with the uterus. So this is adenomyosis, and it's superficial. It's this condition called foam. Focal adenomyosis in the middle myometrium, this macrocystic lesion, that's what this is. This is a retroverted uterus, and here you can see this big hemorrhagic cyst with a very brightly echogenic outline. It was really big, 35 millimeters, and this was in combination with severe endometriosis. And then the last one is called ACOM, and you may have heard of this. This is so the fifth type of focal adenomyosis, my word. And this is an accessory and cavitated uterine mass. This is it on a 3D image. This is the uterine cavity seen at an angle, and this is this uterine mass that is hemorrhagic and intensely painful. It's unilocular. It's the whiteness is this functional endometrium, so it sheds during menses. It used to be called a cystic adenoma, juvenile cystic adenoma, and it's in fact a Müllerian abnormality, which is what we were talking about at the beginning, where you get some duplication of Müllerian tissue at the insertion of the round ligament, so it's in one particular place, always just below the interstitial portion of the fallopian tube. The rest of the uterus is normal on 3D, and that's important that you don't think this is a unicornuate uterus with a rudimentary horn. This looks unicornuate in this view, but that's because it was the only way to get this in, but in fact it had a lovely normal triangular shape in the coronal plane. So an example of an ACOM, this is an 18-year-old girl with horrendous pelvic pain. She was cured by surgery. This is a little video clip of, it's a transverse view of a normal endometrial cavity and then this hemorrhagic cyst with a brightly echogenic central outline. On 3D, the rest of her uterus was normal, and there just below the interstitial portion of the fallopian tube was this hemorrhagic mass. She went to theatre, and that's what it looked like. There's the round ligament, and this was just underneath it. It was removed, and she was completely cured. And if you want to know a bit more about that, this is an excellent paper summarizing all the evidence that we have. So just back to adenomyosis, we talked about diffuse adenomyosis, focal adenomyosis, and all its subcategories. But what is the difference between a fibroid and adenomyosis? And it's very important not to mix the two up. So the difference between a fibroid and adenomyosis, here I've got a fibroid, very well delineated myometrial little mass lesion. This is an adenomyoma. It's usually in continuity, or it starts there with the endometrial cavity, and it is not clearly defined. The kind of shadowing that you get behind a fibroid, as we all know, is this dense shadowing all the way through because it is one consistency, whereas with adenomyosis you get this Luxaflex blind effect. And if you put the color Doppler on, there's vessels in the capsule, so the vascularity only goes around the outside of a fibroid usually, whereas there's no capsule here. The vessels will go straight through the lesion. So these are three simple things to consider when you think, is something a fibroid or is it an adenomyoma? Very important, because if you say that this is a fibroid and the person goes for a myomectomy and the surgeon opens the uterus, they will not find anything that they can scoop out, and they may end up doing a lot of damage. So very important to be correct in your diagnosis. Sometimes you get both, of course. So in this example, you can see a little fibroid there. And then on that side, you can see adenomyosis. You can see here that this is clearly a fibroid, but here you've got the endometrial cavity. This is this diffuse whiteness with little cysts that the vascularity runs straight through. So this is it in a little video clip. You can see the fibroid and you can see the adenomyosis. And so you can clearly see that the two are very different, and on 3D they look different too. This is the 3D of the fibroid and this is the 3D of the adenomyoma. Looks completely different. And here's another example. This person had fibroid and adenomyosis. You can see the adenomyosis is much worse here. There's the fibroid. You've got myometrial cysts, you've got islands just in the transverse plane going up and down through that uterus. And then doing the trace, which is the other way of doing a 3D volume, as I showed you earlier, this immediately came up. There's the fibroid and there's the adenomyoma. So that was a super fast way of showing the difference between the two. Fibroids in 3D, not a big fan because quite often fibroids absorb all the sound and the images on 3D are terrible, but I usually try, ever the optimist. And here you can see a fibroid, and you can see in 2D, you can see the endometrial cavity is close, and on the 3D it came up really nice that this fibroid is displacing the endometrial cavity toward one side. This would become more triangular if I just rotated on it a bit, but you can see that the cavity is being deviated and it is indeed in contact, so it's a submucosal G2 fibroid. And I can't help but show you this. In 2015, this was my first ever 3D scan. I did it with Steve Hussey from GE, and you can see, I mean, anybody could see this, couldn't you? This is a big fibroid polyp indenting a normal endometrial cavity. The uterine fundus would have been here somewhere. You can see the entire cavity going down to the cervical canal. It's just such a lovely picture. So, in conclusion, adenomyosis is very common. It can be very symptomatic. There can be fertility consequences. It's a sister condition of endometriosis, and diagnosing adeno is really important for the management of both the adenomyosis and any coexisting endometriosis. So when you see adenomyosis, you have to think, is there also endometriosis? And that takes us back to the idea classification of the 4 steps. And in this case, we've got a uterus here, as you saw earlier, with severe adenomyosis. And if you look closer at this image, you can see that there's an ovary here with a cyst, and you can see a bowel nodule that's delineated by this very bright submucosa. More of that in a minute. But so if you see adenomyosis, you have to go hunting for endometriosis. The person may well have both, and you can see that was an ovarian endometrioma just there, and then below that you can see deep endometriosis in the uterosacral ligaments and a bowel nodule. So we need to break that down a little bit. If that's the first time you've seen adenomyosis, then it won't make very much sense. So let's start here. Endometriosis. Again, the idea consensus, 4 steps, a systematic routine pelvic ultrasound. We're going to look for features of endometriosis, namely adeno, we've done that, ovarian endometrioma and ovarian adhesions, and then the other 3 steps are here. We'll do them one at a time. In our standard systematic TB scan, I always use an empty bladder, but I don't routinely use bowel prep. The main thing is to be very gentle. Have the patient's bottom overhanging the edge of the couch, don't use a wedge, and use knee supports on the for her knees or feet on a chair. What I say several times during the investigation is say, let your knees go floppy. This makes all the difference in the world. Let your bottom sink into the bed and let your knees go floppy. And say, I will stop. If it's sore, I'll stop straight away. You tell me, and then patients will trust you and you'll get much better views. Very slowly and gently insert your probe with plenty of lubricant and perform your systematic pelvic scan. This is my orientation. Probably most of you scan this way as well, where the bladder is here and the anteverted uterus points toward the bladder. Some people scan this way, but my entire presentations are always in this format. So uterine position, we've got to very quickly talk about that. This is an anteverted uterus toward the bladder. This is a retroverted uterus toward the feet. This one is anteverted but retroflexed, very suggestive of disease behind the uterus, pulling the uterine fundus backwards, and an axial uterus that you don't see so much in young women. Adenomyosis we've done. So in our systematic scan looking for endo, we've looked for adenomyosis already for the direct features and the indirect features. Next, we're going to see where are the ovaries. So normally an ovary is lateral, sitting on the pelvic side wall by the iliac vessels. But if you can't find the ovary there, you've got to take an image showing you looked in the right place. So show the iliacs at the very least. And sometimes, of course, the ovary is very high. It's at the level of the uterine fundus. This is me doing a sliding sign where I'm very gently pressing the probe in and out of the vagina. It's just very gentle movement. Patients won't even notice you doing it. But sometimes, and I guarantee you've all seen this, the ovary is low and you think, gosh, well, what's it doing there? What you've got here, this is the cervix, this is the internal os. This white line is where you've got some bladder attachment to the uterus. This is an anteverted uterus. And here is the ovary at the level of the internal os. If you go to the transverse plane, you can see that there's a ligament here, and this ovary is stuck to that ligament. So the next thing you look for, apart from the position, is what does the ovary look like? Well, here's an ovarian endometrioma. It's using the IOTA language, it's a unilocular cyst. It's got ground glass echogenicity cyst contents. And you can see it's low. It's again sitting at the level of the internal os. It's very important, and we'll show you more. That's called the torus. This ovary is stuck to the torus. If I now go to the transverse plane, internal os, this is the torus. This is one of the ligaments. This endometrioma is stuck to the ligament to the uterus. And if you compare that to her other ovary, which was lateral, it cantilevers when you do that very, very gentle pressing movement. So you can see that here's an endometrioma stuck to the torus, whereas the other ovary is lateral and mobile. In the transverse view, look for kissing ovaries. Transverse, this is the right, ovaries is the left. This is clearly an endometrioma. This probably is too. They can be anechoic. And these ovaries are adherent to each other and to the back of the uterus. So this is kissing ovaries. Now, kissing ovaries, or indeed any ovarian endometrioma, is very rarely isolated, and this was published way back by Katerina Exkustos. If you see an endometrioma, look for deep endometriosis, because you will find some in most people. The other thing to look for is whether the fallopian tubes are involved at all, and sometimes they are. You can have a hydrosalpinx, a hematosalpinx. You can see here clearly that this is hemorrhagic fluid in a fallopian tube. So looking for endometriosis, we've done our systematic routine scan. We're now going to do the sliding sign. I like to do it at this point in the proceedings. So where do you put your probe to do the sliding sign? If you've got an anteverted uterus and you put your probe in the anterior fornix, then you can see the cervix and you can see the movement behind the cervix, cervix against bowel. So this is a good place to have your probe. If in an anteverted uterus you put your probe in the posterior fornix, then you can't see the cervix, you've gone past it, but you can see bowel nodules and adhesions, so very useful for something else. So for the sliding sign, we put the probe in the anterior fornix for an anteverted uterus. So this is the sliding sign. I've got my probe in the anterior fornix. Very gently, all I'm doing, I've got my left hand on the machine. This is my right hand on the probe. Just very, very gentle movement. And I'm looking for movement of the uterus against the bowel. There's the uterus moves one way, bowel moves the other. So there's nice sliding of the bowel against the back of the uterus. Now this is an abnormal sliding sign. Here we've got anteverted uterus, the probe in the anterior fornix, bowel, and this bowel is glued to the back of the uterus. So this is a frozen pelvis. How about a retroverted uterus? If you've got a retroverted uterus and you put your probe in the anterior fornix, then you can see cervix, but we need to look behind the uterus, so it's not very good. But in a retroverted uterus, when you put your probe in, it almost always goes into the posterior fornix. That's just where it goes. You can't see the cervix, can't see it, but you can see the back of the uterus beautifully and sliding of the uterus against the bowel. So that's where we need to put it for a retroverted uterus. So this is a retroverted uterus, so the fundus is pointing toward the patient's feet. There's the probe, this is the pouch of Douglas, this is the bowel. The bowel, as you can see, is moving beautifully against the posterior uterine wall. This is an abnormal sliding sign. You can see again very clearly all this bowel is glued to the entire back wall of the uterus. This is a frozen pelvis. So we've done the systematic routine scan looking for adenomyosis, ovarian endometriomas, ovarian adhesions, looking for the sliding sign in the pouch of Douglas. Now we need to look for nodules of deep endometriosis. So we're going to look for these nodules in the posterior compartment, in the vagina, ligaments, bowel. And this is something I just say to myself, now I'm going to look at the posterior compartments, vagina, ligaments, bowel. So a normal posterior vaginal fornix, you probably don't see this very often. This person happened to have some discharge, so it outlined the cervix really beautifully. Anteverted uterus, probe in the anterior fornix. This is the cervical lip, the anterior lip. This is the posterior lip. This is the external os, cervical canal, internal os. So this is the cervix. You can see that this dark line, that's the vagina, and that's vagina, vagina, vagina. So the vagina attaches to the cervix halfway between the external os and the torus. And in this little pocket is the posterior vaginal fornix. And I've taken a little video clip of that, showing you side to side in the longitudinal plane what that fornix looks like. Posterior is just a pocket really of normal vagina. But the vagina can be affected by endometriosis, so we need to look for Fornicele DE, as it's called. So here I am inserting my probe, normal thin dark line vagina. Now this is vagina, that's the top of the pocket of the posterior vaginal fornix. You can see this is not normal at all. It's very, very thick. It's got hemorrhagic cysts in it. You can see the hemorrhagic cysts, there's several of them, and it should be, the vagina should be a thin dark line, not this lump. So it's very important to diagnose that. And on a speculum examination, pushing the cervix out of the way, you can see it looks a bit like a blood blister. So even many gynecologists wouldn't recognize this. You have to tell them that you've seen it on ultrasound. More deep endometriosis you can see in the ligaments, the torus and uterosacral ligaments, and this is what that looks like. At laparoscopy, we put a camera through the patient's belly button and we're looking toward her feet. So what you can see is you can see the back of the uterus. This is the torus. This is a ligament that inserts onto the back of the torus, and this is the left uterosacral ligament. There's the pouch of Douglas. This is the torus. This is the commonest location of disease. So visualizing the torus, I've got an internal view here of the, I've got a longitudinal view of the internal os. I'm going to rotate on that to the transverse plane. So an anteverted uterus, there's the cervix, there's that bladder attachment. So I've got the bladder attachment, the internal os, and there's the torus. That's where those ligaments attach. So I'm going side to side to center myself, and I'm going to rotate anticlockwise to the transverse plane. The torus is here, and this is one ligament, one uterosacral ligament, and this is another uterosacral ligament. So in a still image in the transverse plane, it looks like this: internal os, torus, and the normal uterosacral ligaments. And you may say, and you wouldn't be wrong, these very fine lines, really? When they're abnormal, you know. So if you've looked in this area and you can't see anything but fine white lines, it's normal. If you look behind the uterus and you see this is called retrocervical fibrosis. You can see all this whiteness there, which we could not see when it was normal, and within that is a lump of deep endometriosis. And if you go to the transverse, you can see that those uterosacral ligaments that were almost impossible to see have become thick white lines, and they often have deep endometriosis nodules within them. So this is called retrocervical fibrosis with deep endometriosis at the torus and into the uterosacral ligaments. There's another way of seeing the uterosacral ligaments, so what I've just shown you, and it's if you imagine that you've got your probe in the vagina, so on the other side here, and you're pressing gently up onto that uterosacral ligament, that if you press laterally to the side, I'll show you there's a uterosacral ligament going to appear here, and when I very gently press a little bit harder, that ligament becomes applied to this area. Here we've got vagina, this is peritoneum, and I'm going to find the uterosacral ligament and press it gently onto the tip of my probe. So this is there it is. Uterosacral ligament being very gently pressed onto the tip of my probe. Now you very rarely see a ligament like that. It's outlined by ovulation fluid, but you can get the point that that's vagina, peritoneum, and the uterosacral ligament. And when you press them together, there's your uterosacral ligament, and you can therefore, by looking at the tip of your probe, find nodules of deep endometriosis that you would not otherwise have seen. What does that look like? Well, here is such a thing. This is the vagina. This whiteness is fibrosis, and it's fibrosis because it's walling off this nodule of deep endometriosis. It's got very spiky edges. To see it, you need to use high frequency, including harmonics, and move your focus up so that all of the beam is focused at the tip of your probe, and then you'll see these nodules if they're there. So we've looked in the posterior compartment for deep endometriosis in the vagina, in the ligaments, and now in the bowel. To visualize bowel nodules, you need to put your probe in the posterior fornix, because in the anterior one you can't really see the bowel that well. most of the time. But in the posterior fornix, you're on the bowel now, so you can see bowel nodules and adhesions. So if we're in an anteverted uterus, we usually are in the anterior fornix. How do we move the probe from anterior to the posterior fornix to that pocket? The way you do it is you need to withdraw your probe very slightly and then angle it backwards. So you can see here I am angling the probe backwards toward the patient's sacrum. So you can see here I'm going to withdraw the probe slightly, angle it backward toward the sacrum, and then gently insert it into the posterior vaginal fornix. And I'm now in the pouch of Douglas, and I can see a pocket of free fluid in the pouch of Douglas. I can see vagina, ligaments. If I went laterally, I'd have the uterosacral ligaments. That's the reflection of the peritoneum in the pouch of Douglas. And here I am, I've pulled it out back into the anterior fornix again. So that's how you move your probe from the anterior fornix to the posterior fornix. Be slow, be gentle, say let your knees go floppy, let your bottom sink into the bed, and by the time you've done this a few times, and gently, patients hardly notice you doing it. There's another way for if people are a little bit more anxious. You start in the longitudinal plane and you rotate your probe to transverse at the level of the internal os. So you're now at the torus. Now at the torus, I'm going to stay in the transverse plane and I'm going to move the probe down toward the sacrum. So that also gets me into the posterior fornix. If I now rotate longitudinal, you can see where I am. I'm in the posterior fornix. It's a slightly more gentle way of putting the probe in the posterior fornix, but you can't examine the bowel particularly well on your way down, which you can in the previous view, as I'm about to show you. So this is a retroverted uterus, and the probe naturally passes into the posterior fornix. That's the most natural place for it. So you can see that I've put my probe in and it's just there. I've got some free fluid. It's just going to sit there naturally. This is what it looks like if I have my probe in the anterior fornix in a retroverted uterus. I can't judge the mobility behind the uterus. I can judge the mobility of the bladder against the cervix, but not the sliding sign, which is the back of the uterus. So once we are in the pouch of Douglas, what can you see? You can see that here's the vagina, that's the peritoneum. If I angle it laterally, I would include the uterosacral ligament. And people say, well, I don't like to scan there because I don't know where I am. But you do know where you are because you've just pushed the uterus out of the way. So just practice this on people and you'll feel more comfortable in that area. What can you see? Here we can see some free fluid in the pouch of Douglas, and this is bowel. This is beautifully outlined because there's some fluid. And there are lots of layers to the bowel. The outer echogenic layer is called the serosa, and then this is the important layer. It's called the muscularis. It's a triple layer, dark, white, dark. There's the outer longitudinal muscle layer, then some connective tissue, and then the inner circular muscle layer. And between them, this muscularis causes peristalsis. So this is the most important layer in the whole of the posterior compartment. Now that is outlined by white submucosa and mucosa at one side, submucosa and mucosa on the other side. Then we've got the muscularis on the posterior wall and serosa. So you can see here that's the anterior wall of the bowel, this is the posterior wall of the bowel, and this is the bowel lumen. Now, very important when you're looking for endometriosis to be able to recognize this triple layer, because this becomes abnormal in nodules, bowel nodules of endometriosis. That's what they look like. You've got that normal triple layer going in, the normal triple layer going out, and this is a bowel nodule of deep endometriosis where that muscle layer has become very disrupted by endometriotic tissue causing fibrosis. So to learn what muscularis look like, if you track it in every time you put the probe in, slowly, gently, let your knees go floppy, let your bottom sink into the bed. Look for the triple line and follow it with your eyes. So I'm very gently inserting the probe. There's the triple line. You recognize it by that little bit of whiteness. There's that triple white line. As I'm passing my probe, I'm following it. You can see it's more obviously triple line here. I'm already at the uterine fundus and I can follow that bowel quite a long distance up. This is called tracking the muscularis layer, and you can track it back down again as well. It's that triple line of dark, white, dark that you can follow all the way up to the uterine fundus. And you don't have to start all the way out. You never see endometriosis beyond about there. But if so, you withdraw your probe from when you can do it going in or later in the proceedings, whenever it suits you. But look for that triple line. Because this is not normal, this is a bowel nodule. So this is the abnormal muscularis. It's got normal going in and out, and it's outlined by this white. That's why you can see it. You've got this lump of dark in white. This is the overlying submucosa and mucosa. And then there you've got some normal muscularis on the back wall of the bowel wall. That is always normal in endometriosis. And so you can see a great disparity between the anterior bowel wall and the posterior bowel wall. Always put colour Doppler on. If this is endometriosis, then it will not have much or any colour. If this is a malignancy, it will. So it's usually pretty obvious the difference. Also, you never get endometriosis in the posterior wall. If it's in the posterior wall, it's not endometriosis. So here's a little video clip of it, so it makes it a bit easier to understand. You can see that triple layer, dark, white, dark, and it goes into and out of this nodule of deep endometriosis with normal submucosa overlying it, and you can see little lumps of deep endometriosis in the uterosacral ligaments as well. And sometimes people have it in all three layers of the posterior compartment, in the vagina, in the retrocervical fibrosis and the ligaments, and a bowel nodule. So vagina, ligaments, bowel. So that's how I always, if I'm in the posterior compartment, I say to myself, I've got to do three things: vagina, ligaments, bowel. If you have all three affected, very important to spot, that's called a rectovaginal nodule. That's palpable on digital examination. Very important for the surgeon to know this before they start, because this is very complex to remove. So bowel endometriosis on 2D is what I've been showing you. You can also do it on 3D. It often doesn't add very much, but if a nodule is at an awkward angle, you take a volume of it and then you can play around with it afterwards. And sometimes it's particularly good for showing you the degree of bowel stenosis. You can see this is normal muscularis front wall, back wall. Here is the nodule of deep endometriosis, and you can see it's a stenosing nodule. That should be the bowel lumen, and at the level of the nodule, that's the bowel lumen. This can become so tight that after surgery, if this is removed, you can't even get your little finger through that. So important to be able to see, and you can get some pretty pictures on 3D. In the anterior compartment, I'm just very quickly going to show you that the bladder can be affected by endometriosis, and there are names for this. You can look for the ureters as they go into the trigone. You can follow those, and you can look for peristalsis. That's one going in, and then we come out the other side, and there'll be an ureter going out of it again. There's the ureter going in, and then, as I said, on the other, this is just in the longitudinal plane, there's the other ureter coming out of the bladder. There we go. And you look for vermiculation if you want to make sure it's a ureter, not a blood vessel, and that's peristalsis in the ureter, squeezing the urine into the bladder. In the transverse plane, you can get lovely color Doppler images, of course, of the urine coming into the bladder. And deep endometriosis, you can get that in the bladder. It's not as common as in the bowel, but look here, the entire posterior wall's been replaced by nodules of deep endometriosis. This one is a bit more typical. It's a nodule of deep endo. You can see the muscularis layer in the bladder wall, and this is a nodule of deep endometriosis in the bladder. Very important to look for. And we always look for the ureters. We look for them at the level of the internal os. We look for them near the bladder. And you've got to look for something that's adherent to the ovary potentially. This is a hemorrhagic cyst. It's very low in the pelvis. Here you can see a vessel-like structure that's dilated higher than the ovary. So increase your depth of field. Look beyond the ovary, and then look at the kidneys. This was a ureter. This is a small hydroureter. You can see it's absolutely plastered to the ovary by fibrosis. This is somebody else, but she might well have had silent hydronephrosis, because 3% of women with endometriosis have exactly that. Very important to look for. So people with endometriosis, quickly look at the kidneys. So I showed you the 2D and there's the 3D. What 3D has added here is that you can see the nodule of deep endometriosis that's gluing the ovary down low in the pelvis, and you can see it almost looks like it's an invasive lesion, doesn't it? Right, so how to practice this? Be gentle. Be gentle is what I'll say to you. You will see so much more. And of course, for the patient, it's extremely important that you are gentle. They have enough pain as it is. Look at the torus, learn how to identify it, look laterally at the uterosacral ligaments, learn how to insert the probe into the posterior fornix. If you do this in people in whom there's not a lot wrong, you will then become really good at it and it will become part of your standard scan. Learn to track muscularis and practice, and do have a look at my YouTube channel if you've got time, because this is such an important subject. Thank you for listening. Thank you.